Good morning, friends. We have discussed about the drugs inhibiting cell wall synthesis, that is penicillins and cephalosporins, and we have also completed discussion regarding the drugs or chemotherapeutic agents acting by inhibiting protein synthesis, that is tetracyclines. We have completed chloramphenicol and we have completed aminoglycoside antibiotics, and the last class we have completed macrolide antibiotics. Is it not? So in the today's class, let us try to go for another class of agents used in chemotherapy. Now, at the very onset, before going for regular discussion, let me ask you a question. Can you identify this chemical present here? Can you see the structure? Can you identify? See, it has been divided into three fragments, fragment A, B and C. Together, what is the name of this chemical? I will give you a clue. See here, the first portion, A ring, is called pteridine ring. Next one is called para-aminobenzoic acid, and third fragment is called glutamic acid. Altogether, combination of three chemicals leads to folic acid. So what is this folic acid, friends? This folic acid is highly important for bacteria as well as human body. Now let us see in what way it is important. So for example, for the bacteria, for growth and multiplication, bacteria needs to undergo three processes basically. Number one is DNA replication. You know that without DNA replication, a cell cannot divide. Okay, then for growth purpose, the DNA should be transcribed into mRNA. That process is called as transcription. Without that, there can be no production of metabolites or enzymes in the body. Third one is translation. That depends upon mRNA. mRNA codes will be converted to proteins. So these three are basic processes for growth and multiplication. And now let us go for DNA and RNA. These DNA or RNA, they essentially possess three chemicals. Okay, what are those? Ribose sugar or deoxyribose sugar, that's one. Second one is phosphates. Then third one is nucleotide bases. Is it not? These are all the raw materials required for DNA and RNA synthesis. Am I right? Okay, so this DNA and RNA synthesis, these three are required. But specifically speaking, when we talk about nucleotide bases, they are basically of two types. What is that? Purines and pyrimidines. Adenine and guanine, cytosine and thymidylate. Correct? Okay, so these pyrimidines, how they are synthesized? In short, they are synthesized by de Novo's pathway. You see, this is the what structure you are seeing it. This is the basic structure of the pyrimidines. You see, in that one of the nitrogen atom present here is donated by aspartate, and one of the carbon atom is donated by carbon dioxide. Then this another nitrogen atom is donated by glycine, and you can see these two nitrogen atoms are donated by glutamate. Last, this second carbon atom, you can see second carbon atom, they are circled there, and eighth carbon atom, they are donated by folic acid. Folic acid means, folic acid is basically inert. It is donated by tetrahydrofolic acid, means a modified version of folic acid is donating. So means without folic acid, there can be no purine synthesis, no adenine, no guanine. So if they are not there, then it is understood that there can be no DNA or no RNA in the cell. Okay, right. Let us come to the pyrimidine section. Pyrimidines, essentially one of the pyrimidine is uridyl monophosphate, which is present in the RNA. Is it not? So when DNA synthesis is there, this uridyl monophosphate is converted to thymidylate monophosphate. You can see thymidylate monophosphate, and this process involves an enzyme under the supervision of an enzyme called thymidylate synthetase. This uridyl monophosphate converted to thymidylate monophosphate, but in this also the tetrahydrofolic acid is involved as a cofactor. Without that, there is no conversion. So means either it is purines or it is pyrimidines, the presence of folic acid is highly essential. Okay, the folic acid is basically metabolically inactive. It is converted to active form by an enzyme called dihydrofolic acid reductase enzyme. You can see DHFR, dihydrofolic acid reductase enzyme. So finally what we will get? We will get tetrahydrofolic acid. This tetrahydrofolic acid, once again to summarize, it is involved, it contributes to purine synthesis, it contributes to interconversion of pyrimidines like uridyl to thymidylate, and it is also involved as a cofactor in single carbon transfer reactions in our body. Okay, for example, that glycine, we told that glycine is also produced under the in the presence of tetrahydrofolic folic acid. Like that, it contributes in various metabolic pathways. Thus, folic acid is very, very important for cell growth and multiplication. That's what we have said. It is highly essential for DNA RNA synthesis. It contributes to cell growth and multiplication. Okay. Then this folic acid in bacteria is synthesized. Okay. Whereas in human beings and other animals, we assimilate it from ready-made sources. Folic acid is accumulated from or assimilated or absorbed from through our diet and food. Okay. Whereas bacteria have got a unique capacity to synthesize their own folic acid. Why they are synthesizing? They can also avail it. No, folic acid is not freely permeable into the bacterial cell, whereas human cell can permeate it. They can permeate it inside. Right? So because of lack of penetration, bacteria have got only one way to acquire this folic acid. That is, they have to synthesize their own folic acid within them. Okay. Here is a scope for selective drug targeting. Is it not? Means human cells are not synthesizing, bacteria are synthesizing it. Okay. So we can interfere with the synthesis process. Na? That's what is today's discussion. Now let us see how we can inhibit it. See here, I will tell you what is the important component of the folic acid. Folic acid possesses PABA. Right? First it combines with dihydroteroate. Then that combination will further be added with glutamic acid. Finally, you are going to get dihydrofolic acid. Is it not? PABA is very, very essential. Now, there are one class of agents, synthetic agents. They are having almost similar structure to that of PABA. You can observe both structures are almost similar or not. Yes, same NH2 group is there, NH2 group, and SOO is there, here COO is there. So, means there is a structural similarity. Due to structural similarity, these class of agents known as sulfonamides, these class of agents will compete with PABA during folic acid synthesis, and they antagonize the synthesis of folic acid. So, when folic acid synthesis is stopped, automatically all these pathways which are depending on that will be affected, or they are inhibited. So, when they are inhibited, bacteria stops growing. So, it inhibits the growth and multiplication of bacteria. This important class of bacteriostatic agents, let us try to concentrate. Okay, right. Now, let us go for sulfonamides. Okay, what are sulfonamides? What are sulfonamides? Sulfonamides are first known, these are the first synthetic agents. Okay, first known broad spectrum. Basically they were broad spectrum, but people won't accept it now because they, due to emergence of antimicrobial resistance among the microorganisms. Most of the microorganisms are resistant now to sulfonamides. Only few are sensitive. However, let us take up the older version only. They are broad spectrum bacteriostatic antimicrobial agents. Means I have already told you, antimicrobial agents or antibacterial agents are the synthetic agents. Okay, and they are derivatives of PABA. All of them are derivatives of PABA. Okay, right. So this is sulfonamides. They are broad spectrum, first known broad spectrum bacteriostatic antimicrobial agents and are derivatives of PABA. Now let us try to see what is their mechanism of action. That's most important part in chemotherapy. See here, mechanism of action. Human cells are freely permeable to folic acid. Here I have stated that point. Okay, and so that's why they acquire from dietary sources. Directly we can absorb it, assimilate it, and accumulate in the body, and our cells will take up this folic acid and use it for their purpose. Whereas bacteria and other microbes cannot take up this folic acid. They are not freely permeable. Hence, they have got only one alternative to have folic acid, that is, they have to synthesize their own folic acid. Right or not? Okay, here comes the point. This folic acid, right, the folic acid synthesis, PABA is very, very important. You see, sulfonamides being structural analogues of the PABA. You see, this is PABA structure and this is sulfonamide structure. Structural resemblance is there. Because of structural resemblance, they competitively antagonize PABA at dihydroteroic acid synthetase enzyme. Okay, so this enzyme, when it is competitively inhibited, then what happens? The folic acid synthesis is stopped. When folic acid synthesis is stopped, see friends, here what happens is subsequently DNA RNA synthesis is stopped and eventually cell growth and multiplication is also stopped. This can be represented schematically like this. You can let us start from the first step. See this here. This is dihydropteridine combines with PABA with the in the presence of enzyme called dihydropteroic acid synthetase. Then you are getting dihydropteroic acid. This combines with glutamate. Then there is formation of dihydrofolic acid. Dihydrofolic acid. So means now active form of folic acid is there. Further it is activated by an enzyme called DHFR, dihydrofolic acid reductase enzyme, and then it is converted to tetrahydrofolic acid and it is metabolically active form. Is it not? This enters into de novo pathway and synthesizes the purines, and it also produces the that is thymidylate monophosphate, and finally it contributes to the DNA and RNA synthesis and bacterial cell growth and multiplication. Is it not? Now what happens here? Now you can just write this also. This is enough for mechanism of action. Sulfonamides being structural analogues of PABA, they competitively, you see this, competitively antagonize PABA and they will block what? Dihydroteroic acid synthetase function. This enzyme function is inhibited. Then you are not going to get the DHF, that is dihydrofolic acid. You will not get tetrahydrofolic acid. You see this process is blocked. When you don't have tetrahydrofolic acid, you will not get thymidylate monophosphate, or you will not get the purines. So then what happens? There is no DNA or RNA synthesis. Then there is no cell growth or cell multiplication. Thus sulfonamides produce bacteriostatic action. Okay, right. So now after this, let us try to see what is the classification. How are they classified? Okay, right. Now let us go like this. See, this is classification. Most of them are rapidly absorbed. All sulfonamides are rapidly absorbed to the extent of 70 to 100%, and they are bound to plasma protein from 10 to 95%. Understanding it? So then the extent of plasma protein binding, if any drug is bound to plasma proteins to high extent, that drug is safe because that will not undergo metabolism. Okay, so that's why what happens, the drug which is bound to plasma protein will be safe from metabolism, so its excretion is also reduced. So thus whichever drug is bound to plasma protein to higher extent will stay for long in your body, means it will have higher duration of action. So now on the basis of this pharmacokinetic parameter, on the basis of duration of action and also absorption capacity, they are classified like this. Number one is systemic sulfonamides. Second class of agents are gut sulfonamides. These gut sulfonamides are taken in oral preparation, but they are not absorbed from GIT or poorly absorbed from GIT. Next one, totally unabsorbable sulfonamides are there. They are used in the topical ointments or lotions or solutions for treatment of eye infections and wounds and burns. Okay, now let us first see the first class of agents, systemic sulfonamides. Those sulfonamides which are acting for 4 to 8 hours, they are called as short acting sulfonamides. Which are acting for 8 to 16 hours, they are intermediate acting sulfonamides. And those which are acting for nearly 1 to 2 days, means 20 to 48 hours, they are called as long acting. Whereas there are some sulfonamides which acts for 7 to 8 days, means more than 1 week they stay in your body, they are called as ultra long acting sulfonamides. You can see the examples of short acting: sulfadizine, sulfadimidine and sulfazoxazole. Next one is sulfamethoxazole and sulfafenazole. Okay, next one is sulfadimethoxine and sulfamethoxypyridazine. Okay, the next ultra long acting is sulfadoxine, very popular. Okay, then next one is sulfaline. I told you some drugs are not absorbed when taken orally. Their action is restricted. Their antibacterial action is restricted to GIT only, and such drugs are used for treatment of ulcerative colitis, and they are also used for treatment of enteritis, and they are also used for irritable bowel symptoms. Okay, right. What drugs are used? Example is sulfaguanidine and sulfasalazine. Sulfasalazine is most important, most popular drug used for treatment of colitis or enteritis, and olsalazine is also used oftenly in clinical practice. Next one is topically used sulfonamides. Okay, For treatment of wounds and burns, some ointments are used. Example, silver sulfadizine ointment. And then mufenide is also used. Mufenide is the drug without the prefix sulfa. It belongs to sulfa category, but it has no prefix called sulfa. Next one is the ophthalmic preparations. Sulfostamide sodium. It is available in 10%, 20%, and 40% strengths, and it is used for treatment of corneal infections. Okay, so this is about the classification of sulfonamides. Okay, next let us try to concentrate on adverse effects of this class, sulfonamides. What are the adverse effects of sulfonamides? Okay, you can see the first side effect is, you should understand, sulfonamides are basically acidic drugs, and human urine is normally acidic in nature. So acidic drugs in acidic urine gets precipitated. These sulfonamides are getting precipitated in the urine, and they form sharp needle-like crystals in the urine. So means the first problem with sulfonamides is they produce crystal urea, and some crystals may pinch the urinary tract and lead to bleeding, condition called as hematuria, blood excreted in the urine. Next, it may damage the structure of nephrons or Bowman's capsule, leading to albuminuria. Then a condition called oliguria may also precipitate, where person gets lesser urine in a day. Okay, then next is anuria. Urine production may completely be stopped, and fatal uremia. Okay, so these are the side effects of sulfonamides on the renal system. Okay, next one is most common hypersensitivity reaction. It produces fever. Okay, it produces fever, rashes, urticaria, exfoliative dermatitis. I told you where skin layers are coming out. Next, photosensitivity, and it also produces one more severe kind of hypersensitivity reaction, that's called Stevens-Johnson's syndrome. In this condition, actually, there are lesions formation on the vital organs of our body, like liver, or in the lungs, or in the heart, or even in the kidney also, lesions formation will take place. So this is a serious hypersensitivity reaction caused by sulfonamides specifically. Okay, next, in 0.1% of patients, sulfonamides may also cause hepatitis due to focal or diffused necrosis in the liver. Okay, next one is, some people will have deficiency of some enzyme called glucose 6-phosphate dehydrogenase. So those G6PD patients are there, they are susceptible for blood dyscrasis when they are taken when they are taking the sulfonamides. Okay, sulfonamide causes hemolytic anemia in patients with G6PD deficiency. Then next problem is kernicterus. This problem is limited only to the woman with terminal stage of pregnancy, 8th or 9th month of pregnancy. The woman is not supposed to take sulfonamides. Next, newborn babies should not be given sulfonamides. Why? Because they will have the high content of bilirubin because of immatured liver. That bilirubin which is there in the body is safe, because it will be accumulated, or it will be bound to plasma protein. As long as it is bound to plasma protein, there will be no harm. Whereas sulfonamides have high affinity for plasma proteins, that's why they will displace the bilirubin from plasma proteins. When plasma proteins are displacing this bilirubin, the released free form of bilirubin crosses blood-brain barrier and accumulated in the brain. That leads to some reduced conscious state, and sometimes total loss of consciousness will be there in the babies. Because of this danger called kernicterus, we are not supposed to give sulfonamides for the woman under terminal stage of pregnancy, or at the end of gestation period, or otherwise they should not be given into the newborn babies because of this threat. Okay, right. Next one is drug-drug interaction. Sulfonamides are highly bound to plasma protein. This character itself is responsible for precipitation of many drug-drug interactions. The other drugs, like we can see phenytoin or talbutamide, hypoglycemic agent, warfarin, anticoagulant, indomethacin, right? Like these agents are there, they are bound to plasma protein. When sulfonamides are given concomitantly, they will replace these drugs from plasma proteins. Then the released free form of these drugs will produce overactivity in the body. The released drug produces overactivity in the body. That overactivity leads to adverse reaction. Means talbutamide, if it is overactive, then it produces hypoglycemia. Warfarin, if it is producing overactivity, then it leads to bleeding tendency. Understood? Like that, it leads to drug-drug interaction. So these are some of the side effects of the sulfonamides: renal toxicity, hypersensitivity reaction, hemolytic anemia in patients with G6PD deficiency, kernicterus, and drug-drug interactions. Okay, right. Now let us concentrate on spectra of sulfonamides. What is the spectra? Earlier, as I told, this sulfonamides were very widely used because of their very broad spectrum of activity. They were active on wide range of microorganisms, but due to emergence of antimicrobial resistance, majority of organisms are now resistant. So only few of the organisms are now sensitive to, presently they are sensitive to sulfonamides. So means sulfonamides are clinically seldom used. They are not used so much in the clinical practice. Presently, what organisms are sensitive? Streptococci, you can see. Enterobacteriaceae. What are Enterobacteriaceae? These are 5 organisms you must be knowing: E. coli, Klebsiella, Shigella, Salmonella, and Proteus organisms. Is it not? These 5 organisms are even today they are sensitive. Then Haemophilus ducreyi, Vibrio cholerae. Some doctors will try it. Tetracycline is preferred. Anyway, you can also try Vibrio cholerae. Now, for most of the cases, sulfonamides have become second or third choice agents, except for uncomplicated urinary tract infection. Anyway, they are also effective on chlamydia, Plasmodium falciparum, malaria causing organism, and Toxoplasma gondii. Okay, toxoplasmosis is a protozoal infection. These 3 organisms are also even today sensitive to sulfonamides. So then, on the basis of this, let us see what is the therapeutic uses. Okay, what are the therapeutic uses? Therapeutic uses are like this. Okay, one is they are used for treatment of uncomplicated urinary tract infections. Okay, then I told you there are some sulfonamides acting locally in the gut. They are used for treatment of ulcerative colitis and enteritis, inflammation in the intestine. Okay, next they can also be used for treatment of streptococcal pharyngitis and also tonsillitis. However, for that penicillins or macrolides are first choice. Even cephalosporins are also used, not sulfonamides. Okay, anyway, next one is sulfadoxine is used in combination with pyrimethamine. This combination of sulfadoxine and pyrimethamine is used to treat several protozoal infections, like it is used to treat malaria and also toxoplasmosis. I have already told you it is transmitted through cats usually, especially it is dangerous for pregnant women, and also immunocompromised individuals, those who are having lesser immunity, for them this infection could be dangerous. Another one commonly found with HIV patients is pneumocytosis. These 3 are protozoal infections. For treatment of them, we can use sulfadoxine and pyrimethamine combination. Finally, they are also used topically to treat conjunctivitis, that is ophthalmic infections, and they are also used to treat wounds and burns. Okay, with this we have completed discussion connected to sulfonamides. Thank you.